really honored to be up on stage here, and I will introduce everyone sort of from my right to left, and we'll just have a conversation. And you know, the purpose, as we've discussed, the purpose of this conference is to foster a dialogue, to create a nonpartisan, policy-agnostic space where the different blind men in the room can talk about the elephant and hopefully piece together an increasingly comprehensive composite of the pathway forward in healthcare. So we are not going to be quite as formal as some of the panels. By that I mean we already have volunteers or some of our team with microphones at the ready. I'm a little blinded. We're all a little blinded by the amount of light. So don't be shy. When you have a question, go ahead and raise your hand, and then Stephanie and Molly will make sure that we get a microphone to you. And then if it seems like we're ignoring you, it's just for lack of sight, and you can just interrupt us and we can carry forward. So first I have the President and Chief Mission Officer of Peace Health, Alan Yorty. Appreciate you being here. The CEO of Family Care Incorporated, Jeff Hetherington. Thank you, sir. Larry Mullins, the President, CEO, both of Samaritan, and not Alyssa Kenny, Representative Alyssa Kenny, but Diane Lund, the Executive Editor of the Lund Report.
Diane Lund, music hand.
Yes, thank you. As I mentioned at lunch, Representative Kenny Geyer's child was ill, and so we tend to like panels that don't only have upper income white men. So I wanted to diversify the perspectives a little bit so we could have a little more of a dynamic conversation. And as we added Diane to our panel, as many of you know, she as an observer and commenter and reporter of journalists in healthcare, one of my friends from a health plan said, "What could go wrong?" I think it'll be great. And I think this is frankly, the kind of honest conversation that we're all here for, right? And so Diane will keep us honest. Alan, I want to start with you. Tell us about your strategic considerations as you think about healthcare today, and maybe specifically Medicaid, but healthcare generally in Oregon. What are you spending your mental energy on as you think about the challenges ahead of your hospital system, Peace Health?
Retirement. Well, aside from that.
See, honest. I love it.
Maybe a little bit of history, because Larry and Diane and I go way back. Larry and I started one of the first, what was then MCOs, still called one of the most successful community health network, doing well back in the early 90s, and then served as Governor Kitzhaber's, first Governor Kitzhaber's chair of the Oregon Health Council. So some would say, you know, you've got somebody who's long in the tooth. Others might say you have somebody who's been around a while. But our issue is, we serve, by the way, Peace Health operates in 3 states. We operate in Oregon, Washington, and Alaska. And I will tell you, I am most encouraged of the places we operate by Oregon. Because despite all the warts and all the issues that we still face with long-term funding, the CCO structure is by far one of the most advanced anywhere in the country. And certainly here in the Northwest. We're still working on the idea of mental health integration in Washington. And the hope now is that maybe by 2020 we'll get there. So when we look at Oregon, I know sometimes it's easy to despair, to think that, boy, we've got a lot of things to think about, but we are also well down the road. And the question, I think, now is sustainability. We, as you know, biennium ago, reduced the amount of general fund allocated to Medicaid. At the same time, we committed to a very significant increase in Medicaid enrollment. And then, God bless Governor Kitzhaber and his staff, went to Washington and got $1.9 billion to backfill some of the hole and to give us a chance to innovate. And now where we find ourselves, I think, for the next 2 or 3 biennia, our single greatest task is going to be how do we bring all of us together, especially many of the stakeholders represented in this room, and figure out how to create a long-term, stable funding source for this extraordinarily innovative program. So that's where I'm focusing a lot of time and energy working on the Medicaid task force and other things.
Yeah, Jeff, you've been outspoken in the Medicaid space. I think one of the more interesting things, and I think courageous, because who knows how it'll work out, that I've seen family care do, is dramatically increase the amount of reimbursement that goes to primary care docs. Something everyone says they'd like to see happen, or rather that primary care ought to be paid more, and you're actually doing it. Sounds like a net, it's revenue neutral at this point. You want to?
Expense neutral.
Exactly, excuse me. Maybe talk about how you're viewing access in Medicaid, the sustainability question, and how you're spending your mental energy.
Well, a couple of things. I'll talk a little bit about the primary care. I think, you know, we all know we're facing a shortage of primary care providers, and primary care providers are paid for their time. That's not something that you can, you know, make more of. So we just decided to bite the bullet. The studies are there. Long-term experience in European countries about robust primary care networks that work better, are cheaper in the long run, and so we raised our primary care rates up to at least the level, and in some cases above the level, of commercial payers. And what we have found is that our access just opened right up. Physicians are more than happy, if they're paid for their time, to spend the time with the patients and to grant them access. And with the Medicaid program, we do know that this population is a tougher population than the general commercial population. So if you don't pay for it, you're not going to get the services you want. Our experience is that our specialty referrals and our procedural referrals for all the testing went down at about the same rate that our primary care costs went up. And that shouldn't have been a surprise to us or anybody else, because that's what all the studies have shown over the years. So we're very happy about that part. Yeah. I would say the other thing that when we start talking about sustainability, and Alan handed it to me on a platter, you didn't know you were doing that.
You can thank me for that later.
Yeah, I will. Is that we hear a lot about bending the cost curve and how we're going to have sustainable funding and all of that. And you know, I think everybody in this room would probably agree that healthcare is too expensive. And how many of you would agree that we spend too much on healthcare? Just raise your hands real quickly. Some of you are hesitant. And then how many of you would agree that there's too much money in healthcare? Very few hands. The truth of the matter, at least my truth, is there's too much money. We have 18% of our GDP. Most of our contemporaries in this world are spending 11%. We not only have enough money, we have way too much. And I think one of the things that never gets discussed in forums like this is how do we start planning for less revenue? And then where do we put our money to make sure that we get the quality we want? But nobody wants to talk about less revenue. That's not a business model we're used to. And I think we have to get to that point at some point.
Larry, at Samaritan, you have first of all, I got to say, I know you by reputation, but I had only spoken with you and known you for a few minutes, and you're already pitching me on bringing our conference to Lebanon. Great advocate for your community. Love that. Samaritan has a health plan and hospital, and you're in a lot of different things. You're sort of, how do you think about this question, particularly on the hospital side or provider side, of less revenue moving forward? You've got a little bit of both perspectives of these other two folks. How do you view that question, or what are you spending your mental energy?
I'll respond to that question, but first I got to say what a unique experience it is being up here with Diane. Truly one of the more knowledgeable
I feel like
people.
We should take a selfie.
But, well, you got to take a selfie.
Yeah, you don't know what I'm going to say yet.
Yeah, well, but the other thing is that at least I know the question won't come from the audience, so it'd be with Diane sitting up here with us. But
the question was going to come one way or the other.
It's going to come one way or the other,
yeah.
but I thought this is a good way to do it, and we're really happy to have this opportunity.
Thank you very much.
Yeah. going back to your question, though, I think what we're focusing on as an integrated delivery network, and Alan kind of referenced it earlier, is operationalizing the policy. So we all know that healthcare, as we know it, and the current funding of it's not sustainable. And I think what our state's done a really good job of, under the governor's leadership, is starting to address and deal with that issue. What I think also self-evident is that it's not a painless transformation. It is almost like a birthing, if you will, of a new model. So what we've been focusing on, and last year in particular we felt it, is positioning the organizations both to absorb the economic impact of healthcare reform and moving into a population health-based model, at the same time that we create the access for the larger population base that is involved in that care. So we've been focusing on that, kind of the heavy lifting stuff. The policy development is an ongoing process. I still think there are things we need to more substantively address, like tort reform and such, as we go forward, because healthcare reform is going to have such a significant impact on all these other issues. And if we leave them unattended, it's going to have consequences for us downstream. So we've been focused on the operational side. 5 hospitals, quick background, 5 hospitals, about 400 employed practitioners throughout the organization, and a health plan. And maybe one of the unique opportunities we had was that our health plan was familiar with our prior experiences of caring for the Oregon Health Plan patients to deal with population health, but we've really expanded that now.
So Diane, I should tell everybody that I asked you and you said, no, I'm not going to be on this stage. And I asked you again, you said, no way. I don't have anything to smart. I don't want to have anything to say. I don't want to do it. And so thank you for coming up here, because I think it makes it more interesting. You look from sort of the outside in. I mean, you're an insider insofar as you're following, but you're not part of the industry. You're an observer of the industry. When we talked before, I think I asked you the question some months ago, what advice would you give to healthcare? And I think your answer was just be more transparent. What do you think about the progress that the healthcare industry is making around transparency or towards transformation, either of those two focuses?
I appreciate the opportunity to be here. I was reluctant to participate, but felt that maybe it was a good idea to raise some provocative questions. As you all know, I have been doing throughout most of my career. I think we have made progress in the industry, but I think there's one sorely needed gap going on right now. We have a global budget payment to the CCOs. We don't know how that money is being distributed. We don't really have transparency. And I think we need, as taxpayers, as citizens of Oregon, as consumers, we need more information on where those pots of money are actually going.
So in Massachusetts, one policy on the table is that all contracts should become, all plan provider contracts should be publicly accessible, the full details of those, so you can see the various levels of reimbursement. Is that something that you think would help? I mean, the providers and plans are not going to be too excited about that, but that's pretty transparent.
Well, I think if we talk about transparency and accountability, we have to basically show what it means, and we're not doing that right now. There was initially some legislation that the boards of the CCOs would be public, and anyone could go there and find out what's really going on, but that was closed down by legislation. And I think it's very difficult to know where the money is going and how it's being divvied up, and I think that it's up to us to basically learn and find that out.
DJ, I'd like to take that comment one step further, because I think there's a real need for an all-payer database, not just for CCOs, but for all payers. I know we're working on that directly in Washington right now and hope to have that in place here in the not-too-distant future. But it's the only way we're really going to be able to see where we're spending money and where we have opportunity, and it's true for all of us. It's consumers, it's providers, it's payers.
And we don't know how much healthcare costs, like other sectors. We don't know how much it really costs for all these different procedures, unless we don't have insurance, which very few people are now uninsured, and then we're told, well, it's $1,000 for an MRI or something else. Or if we have a high deductible plan, then we may find out. But otherwise, there's really no true transparency in our system. And I think it's wrong for us to say and tout we do have a transparent and accountable system when we really do not have that.
Some years ago, the questions I often heard, sort of like, it wasn't really a gotcha question, but kind of a dividing question was, is healthcare a privilege or a right? And I think we've sort of a little bit moved past that. I think to some degree you don't hear it asked as much, but I am curious about how each of you would answer this question, which is there enough money now in healthcare? Is there enough money to solve our problems in healthcare?
Yes, more than enough.
More than enough.
Not being distributed correctly. It's not being distributed correctly. We know there's a huge mental health gap. A lot of the panels today have addressed that. There's huge dental health problems. Why aren't we putting more money into some of those sectors and resolving some of these critical problems? For example, you know, people can't get into a mental hospital, either a state one or a private one. Hospitals won't take them. There's a big long waiting list at the state hospital. Why isn't more money going into mental health care?
Barry?
I think you're right, Dan. I think there's some valid questions that we need to address in terms of a population health type model, mental health being one of the big ones. And when you say, is there enough money in the system, and you consider that, you know, we've grown to 17 to 18% of gross domestic product in terms of healthcare dollars, yeah, I think that's probably adequate. It's the distribution of the dollars. And in the context of talking about the distribution of the dollars, it's also not only how they're being distributed, but what ultimately they do. And I think that's where there's going to be a lot of good work done, and there is right now with the CCOs. And I think some of the inherent transparency that I know you're anxious, and many of us are, to have will become more self-evident. But it's kind of interesting. We're in two worlds if you think about it. We've got a quasi-national state-type system model that's driving it. It's not exactly like the VA system or single payer, but it's getting real close to that envelope. We're creating a CCO model for the activity of how we provide that care, and we're trying to measure healthcare determinants and outcomes with our patients. And I think as we have those conversations, I know one of the biggest challenges we've had is having everybody around that table. So if you want to talk about transparency, when you're suddenly sitting there and you got your partners from the state and public sector, whether it's the counties or the cities, and you got the private sector sitting there, and the independents and so forth and so on, it does change the conversation. And I don't think any of us so much have an issue about transparency, especially if we could have more of a level playing field in that regard. And I'll go back to my tort reform issue, okay? If we were to operate like a health district, we would have capped limitations in terms of our exposure and care of patients, and we would have other regulatory and oversight benefits that would come to us. But as a private sector initiative, which is what our CCO models are really built upon, it's kind of a coalition of different parties, if you will, we're subject to the same risk exposure on the care of those patients. So in other words, it's not necessarily the state backing us up, or the Fed for that matter, if that population requires care. And so as a balance sheet party accountable for it, then sometimes we're more thoughtful about how we deal with that stuff. Okay, so I think I'm all for the transparency side of it, but I think there also needs to be some other considerations and allowances. And I think as we take the CCO model, at some point we'll hit a tipping point. And that tipping point will be when more of our population is being covered under a managed care type model than is currently being cared for with a traditional fee-for-service RVU-based reimbursement. A lot of this will probably naturally happen. And I think the governing groups, at least I know the ones we're with, we have no shortage of people in there trying to look at it. And the contract issue is kind of interesting, if I can take one more minute. Most of our third-party payer contracts have been, and I think still mostly are, there's contractual stipulations that we don't release rates and we don't release terms and conditions. And some of that relates back to some past practices, some of it may relate to antitrust type issues and so forth. So there are real and substantive, and this goes back to what I'm saying, you've got to modify the legal system to allow for the release of information as well as protect the delivery system in the course of doing that. So I think we can get there, Diane, but it's got to be looking both ways.
Don't be shy if you have questions, and then Stephanie and Molly, just make sure you flag me down.
And while we're waiting for some questions, there's another real vagary of our current system that we really haven't addressed yet, and that is that those of us who buy insurance for our employees pay too much in order to be able to ensure that we can deliver care to the public sector. patients that pay not enough in some cases. Now, Jeff has corrected this with primary care, but we haven't corrected it across the board. If certain specialties and certain hospital providers were to simply live alone on the Medicaid payments, for instance, they wouldn't exist tomorrow. And so we have this sort of Robin Hood system that I think there was a proposal here several years ago that maybe Governor Kitzhaber put forward to say, let's throw all the money in a pot and let's figure out what the blended rate is. Because the state covers 42 or 43% of all covered lives here in Oregon. The state pays for that much of our population's care here in Oregon. And if we were to take all the money in that pot and say, what's the blended rate? I think there'd be, to Jeff's point, plenty to go around.
So Jeff, you don't have a hospital, at least you're as a CCO, your health plan. You know, if 55% of the total spend is in inpatient settings, how do you, I mean, it seems like this hospital question, if we're talking about sustainability to either the provider or to the plan, you can't sort of get there from here but by talking about hospital spend. And if it goes to a full managed care model where a hospital is paid a capitated rate, that is a, you know, in a pure capitation rate is sort of a fixed upside in terms of the total amount of revenue you might get, which is not so different from a public utility model that gets a fixed amount to keep its doors open. And the CCO model is premised in part on figuring out a way to pay for empty beds. You're right in that space, and you have gone to war against some hospitals to make sure that the care that is paid for is appropriate care and not inappropriate care. What are your thoughts on how to pay hospitals to be better and keep their beds empty?
Well, first of all, I wouldn't call it war. Maybe terror strikes would be a better appropriate look.
We still have the press here.
Yeah. I still think, I mean, I think there's a problem with the rising, the expansion of the expense in hospital costs. I mean, when we started, it was about 28% of the dollar that we spent on hospitals. Now it's, depending on which CCO you're talking to, it's either 45 up to 54%. So you can't sustain that kind of growth in one area. But I think we make a mistake if we start talking about individual areas to focus on and forget the fact that we have a whole system here, because it is the whole system. I mean, I can, quote, point to the bad guys, and that's what we do in healthcare discussions. We try and, you know, find someone to blame, a scapegoat, and just ride them. But it's the whole system that needs to be looked at carefully, and then objective decisions made, not just pick on one part of the industry or another part. Now, the insurance industry has gotten hit. You know, we're actually the bad people because we're the ones that send out the bills, you know, to the payers. Well, so that's one. Can the insurance industry improve? Yes. I think all of the areas can improve, but once you start there and we start talking, for instance, about specialists, this is just an example. Well, specialists do too many tests and charge too much. That's, you know, we all can agree on that, except for the specialist. And then we forget what it takes to become a specialist and how much it costs, and what kind of debt they come out of medical school with, and how they pay that off. You know, so you got to add in the cost of medical education, the cost of your bachelor's degree, and then let's start taking a look at the tests they do, because are the instruments they're buying, the MRI or whatever, are those priced in such a way that they get good bang for the buck, or are we just giving a huge pot of money to the investors of the you know, the imaging companies? And I think you have to ask all of those questions over the whole range before you start doing that. And I want to make one other point here, because I don't want to let them off the hook. I think you also have to ask the question, what is the proper role of government in this whole area? And I hear some people talking about single payer and some people talking about open market. I think both of those are not sustainable. But when you take a look at the CCO world in Oregon, I agree. We have done a great job with the CCO world. One person's opinion, I think that the regulators in government have lost perspective. You know, delivering health care is not about filling out paper and making reports and data. It's about taking care of people. And when you see an agency that is bigger than it was before we privatized the entire healthcare delivery to the Medicaid population, you have to wonder, you know, there's another expense, and it's not only on the taxpayer side there, but it's also on our side and on the hospital side and everybody else's.
Sure. You want to
respond? Well, let me try to follow up to some of Jeff's comments, because I think he was right on a number of points there that we have to appreciate. We are literally changing an entire part of the society's culture and expectations as we go forward. And I get asked the question a lot, because we happen to be from a part of the state where there's strong single-payer advocacy. Would we accept a single payer? And my typical response is, I would accept an adequate payer. Now, who the payer is what's kind of been driving this model. Historically, it was a third-party payer, and the third-party payer was in large part would help to cover the cost of those who didn't have coverage and were uninsured. Now we're shifting into a model where we're saying, okay, the state's going to take on that accountability, that responsibility. So will there be enough payment there to cover the care that we're going to provide? And so we're going to change the way in which we deliver care. And I think part of the debate that's really not happened yet, maybe because it's not the comfortable one, is so what changes is that going to cause? How is that going to change the interface between the practitioner and the patient themselves? How is that going to change their hospitalization or not? So one fact we know already is that we have seen declines in high acuity hospital admissions. And I think most would say for the best. That's a good thing to have happened, but it's a change in what the patient's expectations are. So it's a very complex process. I think we're started down a good pathway, but we can't ignore all these other factors.
Yeah. Question right here, ma'am.
Thanks. I work for a specialty clinic, and I agree with Jeff. There's plenty of money in the system. But I think we've created a monster in that we have so much overhead in our clinic to deal with the insurance companies, where we have to get pre-authorizations for things that get approved almost 100% of the time. And I know that there's a lot of overhead on the insurance company side to process all those, and it's like something's got to change, because you're right, revenues are going to decrease, but we also have to look at the expense side.
Let me ask Diane. I mean, Jeff says, you know, don't carve it out, and don't carve out one part of the system, and I think that's probably wise counsel. I won't listen for the moment in this question. I asked about hospitals. Somebody said to me here earlier today, you know, health plans of 2014 are pretty much like the health plans of 1984. They're not really that different. They take in claims, they pay claims. Now we have auto adjudication instead of, you know, regular, a medical officer doing all of that work. You've followed health plans. Are they doing enough to justify their value proposition from where you sit?
Are they doing enough? I think that's really questionable. I think it depends which health plan you're talking about. I know if you're talking about Regents Blue Cross Blue Shield, they're spending a tremendous amount of money on for-profit ventures. They have 17 for-profit ventures under their subsidiary of Cambia called Direct Care Solutions. I think others are working more, you know, on patient care and strengthening their physician panels, as was seen. I think that the more increasing notion that's happening now is that we're going to see a lot of corporatization. We're going to see a lot of the health plans, you know, consolidate. For example, we have 16 CCOs, and I think Jeff might agree with me on this one. In 5 years, will we still see 16 CCOs, Jeff?
Yes.
I mean, some of them are very small. Can they really afford to stay in business? Or will healthcare become similar to the banking industry, where you'll have some giant health plans and giant CCOs running the show? I think that's something that we should look for.
I would say Jeff's answer is not supported by the Massachusetts experience. If you look at what happened in Massachusetts in reform, they've been at this same deal now 10 years. They started out with market share of health plans kind of split between 8 or 9 different health plans. And after 10 years, 3 health plans in Massachusetts have roughly 50 to 60% of the market. So huge consolidation.
Right.
Some have left, some have tried to enter now as part of the new
Well, that's what's happening in the hospital world. The independent hospitals are going away. The smaller physician practices, eventually the smaller dental practices. We're seeing a huge amount of consolidation in this industry.
Yeah, I think as payment declines, and I think there will be some decline in payment actually, you will see more pressure to consolidate. Let me put it that way.
You know, I heard. Sure, Larry?
I think Diane's got a good point. We're likely, I think, to see more consolidation occurring, both with the plans and the healthcare delivery systems and the CCO type models. And if you think about it and you look at other industries, airline industry, whatever you want to look at, as you move into this more public quasi-transit type model, consolidation is the natural outcome of that, because you have to achieve the efficiencies. To get to the efficiencies, you got to get the scale. To get the scale, you got to have the balance sheet to fund the enterprise that you're going to have.
But then what happens to access?
Well,
I mean, and then what happens to people that have concerns? Where do they go with their concerns when they have a robot answering the phone rather than a human being?
No, I don't disagree with you, Diane, but I guess the point I'm trying to make with that is that the business model that's going to be sustainable for the future has to work. And if the economics change, you got to have a model that reflects that. We can't just have some vision, some hope for the future and not have a model that doesn't work to where it's sustainable. And right now, what I'm seeing in the industry is a lot of crossing over of all lines. So you got the third-party payers trying to get into the provider space. You got the provider side getting into the third-party payer space. You got both trying to get into the state and federal space. So it's like everybody's out there looking for a partner, but nobody really knows who they want to date. So it's kind of like everybody's trying to figure out how does this work as we go forward. So I think we don't know the answer yet. Yeah. You know, it's a huge
But I think we should hear from Jeff, and he represents CCOs, and I had asked that question of him.
Well, we've been at it 30 years, and a lot of people don't know that, but we started with the Medicaid Managed Care Program in 1985. And it was designed to be local. And then when we did the Oregon Health Plan, it was designed to be local. And when we designed this transformation, it was designed to be local. It was actually proposed to be consolidated in 2009. There were people who wanted to go to just 3 plans throughout the state. That didn't fly with the communities or with the legislature. So I think the thrust will be to keep the health care local. I think what's incumbent on those of us who are health plans to make sure we keep the administrative costs down is to look where we can consolidate our operations where it makes sense. We don't each need to have a TriZetto platform in our own office. We could share those. There are other things where we could share, you know, data analysis and cut down the cost. But I think, you know, Oregon is a little different than Massachusetts. What we have found, and I think we're still finding it, is that the local operations really, A, sell, and B, they've been very successful in Oregon, keeping administration local. So
let me offer this anecdote that I heard about a year ago from a CCO, a board member at a CCO, and this gets to the consolidation point, and it gets to the transparency, and it gets to the sustainability. All of those trends come together, at least in my mind, in this anecdote, which was at the board level, they were looking at the relative spend by provider, And there were 2 critical access hospitals. One was independent, one was part of a large chain. Wasn't anybody up here. And assume the same quality outcomes for a moment. The independent critical access hospital had a cost of X, and the system hospital had a cost of 3X. And so the community the board looked at each other around the table and said, well, how can that be? And looked to the system hospital and said, what's going on? And the answer was effectively that in consolidation, some of the system costs are driven to the local critical access hospital. It's paid at a cost-based methodology. And the local folks in that CCO said, you got to go back to your system and tell them to stop doing that and get those costs out of our market. But if consolidation is the future, and we stick with a cost-based methodology, there's going to be a lot more of that, right? I mean, that is the sort of status quo.
JD, I think you're raising a good example, but I'll give you the reverse of that example, okay? Which is that the theory behind consolidation is, again, you're going to get economies out of scale and out of consolidation. The challenge behind it is what's left after you do that. So much like there might be a system allocation that increases the cost basis at one site, there should be some corresponding savings from that system having interfaced with that site to sustain certain services. And I think, again, this is a transformational thing. We got to appreciate that the model is going to change. And as the economics change, the model will change.
Agreed on all that. However, multiple studies cited by friends at Regents who love to say this sort of thing would note that the Attorney General of Massachusetts produced a study that said price is determined, 75% of prices from market leverage and 25% of prices from cost.
And if I was a third-party payer, I would advocate that too.
Yeah, right. Clearly, market leverage in other industries tends to be a driver of increased costs. Monopoly or oligopoly power in economics would tend towards that outcome.
You opened the door, so I'm going to walk into it here for a minute.
Please.
So all those factors are true, but it depends what is the outcome we're trying to achieve. So if we're saying we want market forces to drive what the price and the competition and the model is, that's not your CCOs, that's not your ACOs. Those are more controlled type models that put a cap on expenditures because it's global budgeting. And that's why I said change how they get paid and you'll change the behavior of what is. So if you're the third party payer now, say you're the CCO, and if we know we got a finite global budget and a certain population to serve, we'll make it work. Now the question is, what's it going to look like when we're done? If I'm a third-party payer, I might say, you know, I like it the way it is, and I can control those costs, control those pressures as best I can. I'm kind of an advocate because I think it's more reflective of the communities for the CCO-type model. And I think it speaks more closely to what those communities want and support. And so for that reason, I like to push the payer and the provider as close together as I can.
So would you argue, Larry, that you know, there may be a series of ways to be transformational, but the most likely successful model will be an integrated delivery model where the payer, the plan, the payer, you know, because the plan might do coordination, and the provider are as closely, maybe they're under the same tax ID, but as closely integrated as possible?
You probably shouldn't have Alan and I in the same panel because that's what we've been working on for the last decade, is an integrated delivery model. And I think if you are in that side of the business, both the provider side and the payer side, yeah, it does work better. Now, it presents challenges, and I can't see where Kelly Kaiser is out there in the audience, but she knows it because as the payer side of the house, she's constantly in tension with the operational side of the house about what things cost. How do we make it more cost effective and so forth. The clinical side, the other operational side, is more concerned with the clinical outcomes, the access to care, and things like that. The three of them together do a really good job, though, because that's when I think we get the optimal outcome.
So,
Alan, I have a simple answer for Diane's question about access. You know, I think if we just let Jeff be the consolidator and pay primary care what he's paying him, access issues go away. I mean, in some seriousness, I say this.
Right.
You know, we've got a system that, from a payment perspective, is a bit upside down. But we also know, if you look at comparative work with other countries that have GDP expenditures in healthcare that are in the 11 to 13% range, we know what they do that's different from what we do. And there are about 5 things. It's real simple. One, they're doing all the administrative work on the insurance side for 7 to 9% instead of 15 to 17.
Yep.
Number one. Number two, all doctors, nurses, healthcare executives, healthcare people get paid about 30% less than we pay here in this country. 3, they spend much less on end-of-life care than we do. And 4, they spend half what we spend on pharmaceuticals and implants because the government buys them. And then there are a few other things.
But that doesn't talk about the hospital costs, which absorb up to 54% of the cost.
Oh, but that's what I was talking about. Everybody in that system gets paid less.
Even hospitals?
Everybody.
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 There's actually a fifth. Not to leave out what you're talking about, because I think those are all important. The fifth one is about 50%, 50 or 60% of their entire provider network is primary care.
Yes, exactly.
That's
a great point. Much more primary care oriented than we are.
Ellen, tying into all of this, I believe, we haven't talked about this, but I believe you are the incoming or the current chair of the Catholic Hospital Association of America?
Current chair of the Catholic Health Association USA board.
I understand from some of my colleagues in Catholic healthcare, not Peace Health, but other organizations, they expect a lot more consolidation in Catholic healthcare across the country, not just in the Northwest. You know, and that's really a function of the Affordable Care Act and other things. What do you see specifically in the horizon in Oregon, but maybe also Washington, related to hospital consolidation, maybe specifically Catholic hospital consolidation?
I don't think this is unique to Catholic hospitals, quite honestly. I think this is going to be across the board. It has happened that many of the Catholic systems that were run by sisters for so many years got started early because the sisters had trouble sustaining them. And so they got together and say, how do we sustain, especially the safety net aspects of what they were doing in communities they were serving. But this is coming to all of us. In terms of the Northwest, you know, we were early consolidators. You may remember, those of you who have been around here in the 80s and 90s, we saw a tremendous amount of consolidation here in Portland. And so we went the days when we had 30 to 40% occupancy here. We consolidated and all of a sudden bumped to 60 to 70 just because some hospitals left. I think we're in for another round, and I don't yet know. I don't think the roadmap to that is clear. I think it will happen by market and other forces. Diane described them, I think, quite well. But those will happen as part of this natural process of continuing to streamline, make the system more efficient. And here's, I guess, the one hope that I have, which is part of why we're all here, that when we do that, we remember the safety net. That we remember that, you know, to Jeff's point, we're here to serve communities and everybody in the community, not just people with insurance or without, but everybody. And that, to me, is the challenge that I hope in all this consolidation we always remember. By one way or another, everybody gets served and everybody has, I'll go back to your question about a right to at least a basic system of health care.
So I, you know, shine a little bit of a light on health plans and hospitals and all that good stuff, specialists. Larry, I'll ask you, what ought your local health care news site be doing better? In other words, there's this, you know, the Lund Report. How do we get information out about the system in a timely way? I don't want Diane to leave the stage without opportunity.
I thought you were getting ready to ask Diane's question for us about consolidation, but maybe just following up on what was just said. I don't think consolidation is necessarily a faith-based generated phenomena as much as it is a sustainability phenomena. So I think in the future you're going to see a lot more crossing of lines of organizations, faith-based and sectarian, if you will, that are looking for ways to make it work, and make it work in a fashion that really achieves that mission and margin outcome. And in some instances, we'll be driven to it out of need, other instances out of choice. But when you say what are the things we can work on every day, The things we're focusing on right now is access to care. We had, and I'm not sure what the phenomenon was throughout the rest of the state, we had double the number of enrollees under the CCO than what was projected. So we suddenly had 19,000 new patients that we were accountable for within our service area. We thought we were going to have 8,000. So one of the things we're focusing on is creating access to care. Now, what do you do when you're trying to create access? We're asking our practitioners to practice more. We're saying see more patients in the clinical setting. Well, that has dynamics and changes to it. We're trying to look at different delivery models as we go there, and we're trying to make sure we got the economics in play to sustain that as we go forward. So access is a big one.
Any advice you want to give Diane to how she should operate her website?
I think Diane does a fine job operating her
Thank you. I
website.
appreciate that. If you want to give me any tips, any
I'm not
off-the-record
gonna give you any
information,
quotes either.
be happy to, you know, to hear it.
You read the London Report, right?
No.
You don't read the London Report?
Diana, here, I can give you
Yeah,
my
I do.
coupon.
Yeah, I was going to say, Diane's
my
been trying to
coupon.
get an interview for how many months now, and then we end up on the stage together.
I know.
Yes.
But we only got about 30
I
seconds.
just want to say also, if I can, this is the start tonight of the Jewish New Year.
Yes.
And so in Shana Tova to everybody, whether you're Jewish or not, it's the start of the year 5,775.
Absolutely.
So on this, before we get to Rosh Hashanah and conclude our day here, Alan, and I'll ask everybody this question, but concluding comment, 1 minute bit of advice to this audience.
I think the more we recognize the common interests we have rather than the differences we have, the better off we'll be, especially going into legislative sessions where there's so much important work in the state to be funded. So I think building bridges is much more important than seeing differences.
Building bridges. Jeff, 1 minute bit of advice.
Well, I already talked about, I think we need to just look at how we reduce the amount of money in the healthcare system. I think the one thing that I would say with regard to consolidation and where we're going to be in the future, healthcare is not about all of us who have jobs in healthcare. It's about the people we serve. And one of the things that I've seen, and I experience it in my own organization, is we seem to think that we need more employees. And, you know, the more we spend, over to the specialty thing, the more we spend on healthcare and on administration and all that, the more it's going to cost you all. And I think we need to always keep in mind from